All right. As a psychiatrist, researcher, writer, and advocate, Dr. Bessel van der Kolk has played a paramount role in forging the field of complex trauma. Much of his research has been investigating the distinct impact of trauma at different stages of development, as well as how disruptions in caregiving systems have additional deleterious effects. Impassioned by his research findings, Dr. van der Kolk has devoted himself to improving the efficacy and access of treatment interventions. In 1984, he set up one of the first clinical research centers in the country dedicated to the study and treatment of traumatic stress in civilian populations. One of the first professionals to identify complex trauma, his work directly led to the establishment of the National Child Traumatic Stress Network, which reaches 100,000 children and families. A testament to the powerful way he writes about trauma, his New York Times bestseller, The Body Keeps the Score, has returned to #1 for paperback nonfiction during the pandemic. His book, mirroring his professional achievements, not only conveys a felt sense of the immeasurable suffering caused by trauma, but also instills hope that recovery is possible. Along these lines, Dr. van der Kolk is known for researching new and unconventional treatments. He was an investigator on the first studies examining the treatment of potential SSRIs for PTSD, was NIH funded to research yoga as a treatment for PTSD and theater as a youth violence prevention. Now, he is an investigator on the multi-site phase 3 studies of MDMA-assisted psychotherapy for PTSD. For the next hour, Dr. van der Kolk and Dr. Rachel Yehuda, the director of our Center for Psychedelic Psychotherapy and Trauma Research at Mount Sinai, and a pioneering translational researcher in traumatic stress studies, will discuss the promises and perils of psychedelics as treatment for complex trauma. Please type questions in the Q&A box for an interactive session at the end of the hour. But without further ado, Dr. Yehuda.
Thank you very much, Dr. Lupau, for that beautiful introduction of one of really my longtime great friends, Dr. Bessel van der Kolk. And I'm so happy to have you here, and couldn't be more thrilled that we will be having this conversation. You and I go way, way back. We have both been there since the early origins of PTSD research, and some of my fondest memories are of you and I walking through cities, spending all day literally walking through Stockholm and Rome and the Vatican and climbing Masada, Melbourne, and each of those days were spent talking about what was going on in the field of trauma and how it was progressing. So thank you very much, Bessel, for being here.
I'm actually surprised myself by being very touched by what you're saying here. Like, people actually always like, wow. Because it has been a very beautiful evolution, hasn't it? And it's been really great to have been there together sort of at the beginning of this field and seeing it evolve. And it's actually, I'm very touched by being aware of that. Yeah.
Well, it's been great, especially since we've come from different frameworks, for sure. Yeah. We have seen eye to eye on many, many things. Not everything, I think just enough to make it interesting.
Just to make it a bit lively, yeah.
Just to make it a bit lively. And now we're collaborating again. We're very excited to be writing up some of the phase 3 data from MAPS. Yep. So it's just rekindled all that fun. But I want to give our audience and our listeners just a real sense of how pioneering your vision has been. And I was there while I was there to see it happening. One of the things that we used to talk about a lot was our concerns really with how evidence-based research in PTSD, especially with respect to treatments, was evolving and shaping the field. And I believe that a lot of those concerns that we talked about were what prompted you to write The Body Keeps the Score. So could you tell us a little bit about what led you to writing The Body Keeps the Score from the perspective of these concerns?
Well, my most immediate inspiration was I've been on various admissions committees for medical schools and residency training programs at Harvard and at Boston University. And I always ask people, what books have you read that you found particularly inspiring? And if you would ask me, what books did you read that inspired you before you ever became a psychiatrist? Okay, well, that one. And in the last 15 years or so, none of the applicants could come up with a book that had inspired them. And I go, oh my God, here. And what I also saw is that psychiatry became more and more of a sterile profession and became a drug pushing thing. Like, that's not psychiatry. Psychiatry is about the mind and systems that people live in and families and executive functioning, how well they are in terms of taking hold of their lives. And I wrote a book to inspire young people to go like, this is the most interesting thing I can do with my life. How I mean, you can put the brain together with neuroendocrinology, with social situations, with historical traumas, our incredible need to go to war and to glorify it. All of these things come together in traumatic stress. And there's great literature in it, there's great movies in it. So it brings so much together in terms of the totality of life, including, maybe most of all, how people go through horrendous experiences and lift themselves up and go on somehow with their lives by hook or by crook. And I don't like to call that resiliency. Everybody who I know has been traumatized, I call resilient. But I hear their stories, I go like, oh my God, how come you're still here? I can't imagine having gone through anything like that myself. And you're still motivated, you're still trying to do things. Good for you. Because we've discovered how damaged people become, how damaged their brains are, how complicated their minds are. And we're dealing with an incredible damage of reality. And we have barely scratched the surface in terms of how we can help.
Yeah, so that's I agree with you about using the word resilience in the way that we sometimes use it, and also agree that everybody struggles with things, and just this idea of that you're going to keep going. Where does the concept of PTSD fit into this? How do you think, what is the best way to think about PTSD, the way that it was conceptualized, and where does complex PTSD come into this picture?
Well, you may not agree on that, but I was even here even before you. So I was part of the team who interviewed people for the PTSD diagnosis. So there was not a real field trial, but we just submitted a lot of case histories. And what was going on is that the Vietnam War was over. We saw this formerly powerful men who were broken. And they would come to our clinic and say, I've become a monster. Nobody is safe with me. I can't trust what I do. I blow up at people. I wake up in the middle of the night strangling my girlfriend. I have these cute kids and I can't feel anything for them. And what we saw is impulse issues and relational issues. But we're at the VA and we have to convince people this is about the war. I happen to be very interested in the recurrent recollection because at that point I was a sleep researcher. And we discovered that traumatic nightmares occur in stage 3 and 4 sleep, that they're not REM sleep, and they seem to be exact relivings of trauma. And so the memory issue is terribly important, but it's secondary to the issue of how you cannot orient yourself to your world. Pierre Genet, who became a very important person in my thinking, said back in 1889, le traumatisme is a disease of présentification. It's an illness of not being able to be in the present. That is as good a definition as I know. And yes, the memories are part of it, but all the adaptations of trying not to feel, trying not to re-experience, become very complex things that ruin your reality of your current life. So your life becomes impoverished. And then Genet again says, fighting this takes so much energy that all traumatized people have the evolution of their lives halted because they're attached to the terrible thing. And that gets me into, together with other things, into Piaget and how people have different mental functioning at different ages, and that so many of the people who I see seem to be stuck at a level of being a 3-year-old or a 5-year-old, even though they're grown up. So I get very intrigued with how trauma shapes people's mental capacities very much according to the age at which the trauma occurs, and it's different for different ages. We talked about it the other day. I think hardly anybody of us ever gets to see pure PTSD. It's always one thing on top of another. And then I say it became a memory diagnosis. And I think it may be becoming a memory diagnosis. We had to do it because everything in life is political. So you yeah, go.
I'm gonna just backtrack to something
Right.
you said. I think that'll give you an opening for what you're going to say next. You talked about the definition, as good a definition as any, about PTSD is trauma is not being able to be in the present moment. What do you think about the idea that treatments of PTSD, conventional trauma-focused treatments, believe that confrontation with the past and confrontation with a traumatic memory is essential for healing? And maybe that ties into this idea that you just started to talk about the premium, the centrality, I guess, of traumatic memories as a hallmark symptom in PTSD. So what do you think about the need to revisit the trauma versus being in the present?
I think that's a core question. And depending on what day you ask me that question, you'll get different answers. I think people, like, let's say you're a teenager and you have been horribly abused at home, and your first boyfriend or your first girlfriend are a real caring person. That first experience of saying, oh, the reality can be different. I can feel taken care of. I can feel loved. At a critical period of brain development can completely change people's mind. Basic training is a very great example. I mean, people should learn more about basic training. Many people who join the armed services have very, very disruptive backgrounds, and they have a lot of prior abuse histories. But you do basic training, and after 12 weeks of doing these things, you feel like, wow, I'm okay. I'm an amazing person. So they have a visceral body experience of competency and belonging. They don't visit their past. Doesn't therefore resolve it? I'm not sure. And the word I don't like what you say is confrontation with the past and to eradicate the past. And that's where I have a very fundamental difference, is that the past needs to be integrated, not confronted. And so the whole issue, and it's very relevant for psychedelics, because that's exactly what seems to happen. If you need to go there and to, on a very deep precognitive level, no, that was then, and this is now. I could even tell you about some of my own experiences where these experiences are not fun. You and I have never talked about our own experience, but stuff comes up. But on psychedelics, you can go like, oh my God, this is awful. And so last time I actually did MDMA myself, I went, that poor kid, because I remembered what it must have been like for me to live in the final years of the Second World War with starvation and death all around me and being very, very sick. And I go, that poor little kid. But it's not a confrontation. It was accessing it like, oh, that's what it was like back then. And you can make that separation between past and present.
Do you think that it's possible to heal from trauma without going back there, however you want to call it, and integrating the past? Or more, can you have more of like a Buddhist approach of being in the here and now and doing things that can make you feel loved and nurtured now? Because that seems to be what you're saying, that you can have a corrective experience and maybe not integrate the past?
It's integration of the past. But see, the Buddhist experience is beautiful, except when you start doing intense meditation with very traumatized people, they visited trauma. And Willoughby Britain just is being funded right now about the dangers of meditation, because if you don't have a lot of trauma, you can become still and deal with all this stuff. But most of my traumatized people flunked out of these courses because the trauma is not about the past. The trauma is how the past lives inside of you in the present. And so the moment you become mindful, you meet all that terror of the past. And we see this all the time in the work that we do. People don't want to meet themselves. They're happy to tell a story about something that happened a long time ago because it gets them away from these sensations in their body that really carry the imprint of the trauma.
Yes. And is that one of the fundamental critiques that you have of evidence-based trauma-focused therapies?
Well, you can call it evidence-based. Okay, they got some grants that show that people get 10%.
Trauma-focused cognitive behavioral approaches.
See, I think one of the things that really was hard on our field is the emphasis on evidence-based. Why? We're both researchers. We both study how things work, but a really very intricate psychological intervention is very hard to protocolize. And so these most simplistic treatments have become protocolized. Say, oh, that's evidence-based treatment. And you go like, well, it gets people better by 10%, if you're lucky, but that doesn't cure people. And they do EMDR, and 80% of our adult onset PTSD people who had a good childhood, no more PTSD. It's not like they get a little bit better, it's gone. And so our evidence-based really got us into courses instead of exploring how can we do better than this, because our results aren't very good. A 10% improvement on your PTSD score is not satisfying. And what else can we do? And what else can we do became very difficult because it's almost impossible to get grants for anything other but a top-down approach.
Right, but you must agree that it is important to be able to guide a field of academic medicine or psychiatry based on research that people do, Absolutely. Even if it's hard. And so
that's what I've done. I've studied all these different things. I'm somewhat suspicious of people who find one treatment that's not particularly effective and say, I found the evidence-based treatment, and spend the whole rest of their lives sticking to that treatment. Are you really a researcher? Or you're just sort of stuck in getting your next grant about your particular method? That is not very interesting to me or admirable.
Yeah. No, but I think that...
you are of my ilk.
I am of your ilk in that I think that we should challenge ourselves to study things that are difficult. And that we sometimes do go for the low-hanging fruit. I mean, cognitive behavioral approaches really have used an extinction fear model to justify this idea that that techniques like desensitization and habituation might result in extinguishing a fear response, and that it works because it has a theory, it has an animal basis. It does seem to work in some cases, but particularly I think the simpler cases where there is kind of an adult onset to a very concrete event with a beginning and end.
Yeah, and even for kids, if kids have caring and loving parents and they get traumatized by something, the CBT is quite effective. But if your mom is the source of your trauma, that's a little bit more complicated.
That's right. So I guess what people might be very interested in here is really this idea of whether treating a simple case of a concrete finite trauma is different than a situation where there has been a lot of developmental exposures, where the home that's supposed to be your nice, safe place really becomes the dangerous environment, and there isn't anybody there to kind of give you a different message that you can be safe. And that has been called complex PTSD unofficially, right? Because complex PTSD is just something we say because calling that PTSD and it doesn't seem to be an equivalency. So the question is really whether that label of complex PTSD, we certainly understand how it pertains to an experience, but what do you think about treatment? I mean, does it require different treatment interventions?
Oh, absolutely. Because having a drunken alcoholic father who beats you up on a regular basis and molests members of your household is not an event. It becomes your experience of life. It becomes your identity. It becomes who you are. And, again, that's how we defined PTSD back in 1980. We said people have been exposed to a horrendous event outside of normal human experience. How blind were we that we didn't know that these events are not outside of normal human experience? How many women get raped? How many kids get abused? There are millions of them. And we said, this is exceptional because this particular event. But for many people, it's an ongoing part of their lives that determines their identity, their perceptions of the world, and their neurobiology, depending different types. But we're leaving out, surprising for the VA, is the attachment system. Because, of course, soldiering is entirely based on the attachment system because basic training really helps people to form very close ties to their fellow soldiers, which is what helps them to get through the war. And the very first piece of research that I did dug up that losing your friends in the war was a trauma.
Yes. Let me go back. You said a few really important things that I want to open up. The first question I would ask you is what do you think the necessary components are of healing from developmental trauma?
The most important thing is feeling safe in your own body.
Okay.
Not getting signals of fear, fright, danger, rage, the sensation. Darwin in 1872, Emotional Expression of Animals and Man, says emotions are about physical sensations that are meant to make you move. That's why it's called emotion.
But I would argue that that would also apply to us a case of non-complex PTSD. Just this idea of being safe in your body seems to be something that would have in common, because I'm trying to lead us into the potential of psychedelics, which I think psychedelics have potential for both one-shot events and for very complex developmental traumas. And the efficacy of psychedelics, and particularly MDMA, the fact that it works for both things seems to challenge the idea that if there is a very complex developmental trauma, you really need to do something different than if there is a single event, because the idea of achieving safety in your body, that seems to be where you can go, right?
We did a piece of research in the early 90s, it's probably the research program in the late 80s actually, looking at people's background and their response to treatment. And we found that if people could not remember feeling safe with anybody as a child, that they could not make use of psychotherapy because there's no imprint of being safely held in a way. And that's why adult onset trauma is so easy to treat, at least from my perspective, because people can remember what it felt like to be loved. People remembered what it felt like to have fun and to feel safe. And that what makes complex trauma so difficult is that it's so hard to get to a state of safety and surrender and being able to go there. I thought it was a very important paper that I wrote back then. I don't see it actually ever being quoted, but that's an important finding. If you have no safe introjects, no memory of being cared for and loved, it's very hard today to feel safe in your body. And that's where the psychedelics came in. There's also a yoga came in.
Okay, well, let's pivot to psychedelics then, because can psychedelics make you feel safe in your body if you haven't had the experience before of feeling safe in your body? And if so, how do you think that what do you think is going on to allow that to occur?
I think that's the great question that we need to answer. So I told you that before I got involved in the MAP study, I talked to Rick and Michael and said, don't include people who have no post-traumatic stress disorder, who have always traumatic, who have no memory of a pre-traumatic existence. Because those people in all of my studies I've done do not do well. And they'll screw up your sample. And it's just too complex a sample to study. I was overruled. In this case, I was happy I was overruled. That's what's the great thing about doing research is you have an idea and you put the data in and you go, wow, I had not expected that. So what did we find? The first finding is that the dissociative subtype of PTSD, which is almost impossible to treat, those people did better. And the people who didn't have those, like, wow. Because when you're dissociated, you're out of it. And when you're out of it, you cannot access yourself. And so what happened? I mean, that's a huge finding. Huh? And the next thing is that we find out that almost all of our participants had developmental trauma, almost all of them, which is very typical for the people who I see in my life. And I suspect the people you see in the VA also. Because you're in the VA culture, you blame it on the war. But boy, when you look at what happened to them before, you see much more than that. And so what is astonishing is these data on self-compassion. And, you know, one thing that stands out about when you have been abused and neglected as a kid, you feel like this happened to me because I'm a terrible person. And they know that this not logically doesn't make sense. So telling them it wasn't your fault, you're just a little kid, doesn't change anything because they feel fundamentally bad and deficient. And when we measure that, they're okay. They get this sense of, I'm okay, it wasn't my fault. Not because of any input from the outside, but these MDMA particularly, I wonder about the other drugs, possibly also, get people in the state of self-compassion. And so what you see clinically when you do your MDMA sessions is that there no picnic. I was just in academy training and 30 people were going through it. One guy said, I just spent the last 3 hours talking to God. I go, that's cool. I've never had that experience. But for the majority of people, when they close their eyes, they go deep inside. A lot of painful stuff comes up. And I know it for myself also because I've done it. And then you notice what happened back there and you go like, that poor kid. That kid, nobody was there for that kid. And so in some way that may not appeal to you with your particular scientific background, is you take care of that child inside of you who got so wounded. And it's very painful, but you have a degree of relationship to yourself that is, and you saw the data, I mean, that's what we're writing up right now, of a sense, a terrible thing happened to this kid, and then I need to take care of me. Huh? So it allows people to go into these internal networks, which we all know is so critical for healing, and these interoceptive systems, and they meet themselves, and they go like, oh my God. And it's totally non-cognitive, but after you allow yourself to go there very gently, that's why I don't like the word confrontation here at all, very gently, you go there and you go, yeah, okay. And hopefully you have a sitter with you who is very kind. I just want to, before we leave it out, don't do the experiences outside of a therapeutic environment. Don't have people blow their minds in their homes by themselves. These are potentially very dangerous substances because stuff comes up. And it's very important to create a place where people feel held, and people may be yelling and screaming as stuff comes up, and you need to be there for them. I say, it's okay. I'm here for you. So that context is terribly important.
So maybe say a little bit more about that, because MDMA, people talk about that it is a very safe drug, and that in a non-clinical setting produces euphoria. It's nicknamed ecstasy.
Yeah.
What are your concerns about somebody taking this drug at home in order to kind of access an inner cognitive state?
Well, I've never taken MDMA for social settings. I missed out on that. But people always say they feel open-hearted, they feel generous, they feel warm when they engage with other people. But when you do your MDMA trauma experience, you have a blindfold and you go inside. And you become social with yourself to some degree, but you get to know this creature who is you. But actually, another indeed stunning part of the current MDMA trial is that we have had not a single bad side effect. That's because it's such a carefully done study. Because you're studying it yourself. It's a real pain in the ass study because we do so much to make sure that people are okay. It's such a very careful creation of a cocoon for people to have these very, very profound experiences. Many of them are quite painful, actually.
So, Bessel, you said that you were advising the design of the MAPS trial to not include people with developmental traumas or people that had these complex presentations, and you're glad they didn't listen, because
Boy, am I glad.
Those were the people that did very well, and particularly people in the dissociative subtype did well. So even though you got that wrong, what would you say sitting here today about?
You know what it's like. You're doing science, it could be wrong,
No, but I'm wondering if seriously you have a concern about any particular clinical presentation or particular phenotype, or as something of somebody that you wouldn't recommend the experience, even in the guided, safe way in which it is offered in clinical trials.
Yeah, I'd be very concerned for people who have very low executive functioning, who cannot organize themselves around a particular task, whose filters they just cannot activate the salience network in the right way and the executive network in the right way. So if people are too out of it, I'd be very, very careful with them. But then the surprising thing, and that's going to be, again, why we do the research, is how pathological can people be and still benefit from it. And I continue to have grave concerns about that.
But there's
our data really show that it's quite safe. Yeah.
But I struggle with this too, because on the one hand, we want to think about the psychedelic therapy experience as not being too cognitive, as being more experiential, more accessing feelings in your body, and yet to not have executive function, you're pointing to really cognitive functioning. And so it's a bit of a paradox, right?
It is.
So for cognitive behavioral therapy, people really don't do well in those therapies if they don't have imagination, if they don't have flexibility, if they can't think about things differently, if they don't show cognitive flexibility.
If they can't observe themselves and all that stuff, yeah. Mm-hmm.
Right. And so I'm wondering if the same skills that are required to do well in trauma-focused therapies are also required to do well here, or not.
As Rachel Yehuda would say, that's an empirical question. And a very important empirical question that we should inculcate in our research design.
Yeah.
I felt really sad that we did this $30 million study, and the main outcome is PTSD. I always like to say that John McCain had a high PTSD score. He was a senator. And the guy lying on the bridge next to my house has the same PTSD score, but he's completely incapacitated. So PTSD is just a small piece of the whole problem. And so the issue of being able to observe yourself, being able to articulate who you are, to know what you need, know what you want, to actually have the lights go on inside of your mind about this is me and this is my life, which is oftentimes very impaired and very traumatized people. We should study that.
Yeah. So what you're talking about, and I agree with you, is that there seems to be two orthogonal dimensions. One is PTSD symptom severity, and one is functional ability, and that they're not necessarily related, or they should be, right? One would think that if you have really, really severe PTSD symptom severity, you should not be able to function very well. But what do you make of that? Yeah. But so what does that tell us, if anything, about the utility of the diagnosis of PTSD or lack thereof?
Well, I think, what we see in PTSD is a real thing, of having flashbacks, behaving and feeling as if you're back there and numbing yourself out is an absolutely a discrete thing. But depending on when it happened, it has a very different impact. So like in the Harvard Grant study, all these guys went to Harvard, Second World War. Few of them got PTSD. And the people who got PTSD functioned better than the people without PTSD because they hid themselves in their work. And they had more listings in who is who in America than the non-traumatized group. So having a solid background in getting traumatized, some people are able to get it together and hide themselves in their work. Their kids hated them, their wives couldn't stand them, but their work people really saw them as very resilient. And so, but if the same thing would have happened to them when they were 2 years old at the hands of their own parents, you would get some PTSD symptoms, although most abused kids don't meet criteria for PTSD, but you get a whole issue of identity and functioning and not being able to learn, not able to take in information, which is a very different adaptation.
So that's interesting. I'm going to ask you, I think, one more question and then turn it over to the audience. And this is a question that I get asked. So I have my own opinions on it, but I'm just wondering if you think that people require treatment as a result of having severe trauma exposure, or whether what brings people to treatment ought to be an impairment in the way that they function. I mean, is there such a thing as treating trauma, or is there something else? I think you probably know what I think, but I'm just really wondering.
You and I would probably agree with that.
What?
We are trauma informed. I don't know what the hell you mean with that.
I also don't.
I have a friendly debate with Nadine Burke-Harris, the health czar of California, and she was very hurt that I said what I said. And I said, I can't help it. She's getting trauma histories on all the kids in the California school system. And I go like, that is dangerous information. If anybody gets a hold of that, they know the actuarial tables that will condemn these kids for life. No, what you should do is to help these kids to regulate and to form rhythmical continuity with other kids so they can be in the present. So you should create school systems where kids can feel seen and safe, and that you don't bring up the trauma. Because people seek treatment for their trauma.
But you shouldn't do trauma screens.
Not in schools.
You shouldn't screen from trauma.
No, I don't think so.
Okay. And so what about for going into the military?
The moment it's in your record, it's very dangerous information.
So if you learned that somebody had...
What?
But Bessel, if you learned that somebody had an extreme trauma, would you say to yourself or them, you really should speak to someone because of this incident?
Oh, absolutely. No,
so you should treat trauma.
Absolutely. We should also treat it. No, we should not treat the trauma. We should treat the secondary effect of trauma of blowing up at people. and not being able to focus and not being able to learn and not being able to form friendships with people. That is the issue. It's not the traumatic memories. People have these somatic reactions to minor stimuli that messes up their lives. So how does PTSD express itself? You blow up one marriage after another because you get too angry and you shut down to have a relationship. And that's the issue. You could say, oh, the trauma. Yeah, the trauma started all this, but by now there is mental and physiological processes that keep you stuck over there and keep intervene with what you in your current life. But life is for the living. So revisiting the past over and over again is actually a very important thing, because you probably know Ruth Lannings's work about the default mode network, is that when you're traumatized, the default network is sort of gone when you're quiet and nothing is happening, but your default network gets activated when you're in a traumatic situation. So their brains are reconfigured to be very good in very scary situations, and they feel nothing when life is not scary. Well, if there ever was a clinical challenge, that's a clinical challenge.
Yes. I changed my mind. I'm going to ask you one last question. And that is, what, if anything, are you most worried about as the psychedelic field matures and research goes forward?
What I'm most worried about is that people cut corners. The commercialization will take over, as already has happened to a large degree in ketamine. People will not see this as I'm going to use the word, as a sacred process. Mm. That may be offensive for people who label themselves scientists, but when you do this stuff, you get to know something what people mean with sacred also.
Yes.
And like the people at Hopkins, they're very admirable people, and they always have been able to keep both things in mind in a way. And I admire them for not cutting out that piece, actually.
Well, I want to thank you very much for having this fireside chat with me. Is there anything that you wanted to say that I didn't ask you about? If not, we'll go into the questions.
I hope we have many hours to talk about stuff. Yeah.
God willing, Bessel. God willing. Okay. I'm going to turn this over to Lauren right now to see. We have quite a lot of questions on the Q&A, and some people might want to come up and ask them in person. But some of these are really terrific questions. Thank you.
Yes, thank you so much. We do have our first question from Dr. Garrett Deckel. So yeah, please unmute yourself.
Hi, it's an honor to be here today. Thank you. I'm a specialist in dissociative disorders and therefore also complex PTSD. And I'm always a little puzzled when people say they're surprised that the dissociative subtype did well, because I understand dissociative responses not as being out of it, although they can be. But if I love that you brought in Gen A and presentification, because I totally agree with that way of thinking about it. But it's sort of part of what in PTSD fights presentification, that dissociation is a fear-based separation, as I understand it. Dissociative processes are a fear-based separation from the unbearable aspects of the present. And then it seems to me that psychedelics, and especially MDMA, it makes a lot of sense that they'd be perfect for people with dissociation, because they do make the present bearable. People with dissociation aren't just like going around out of it all the time. Yeah. It's a process that comes and goes.
No, I think there's a very valid point, but we also know that people develop dissociative disorder because the confrontation with reality was unbearable to them. So they split it off. And so my thought is also, once any intervention brings this stuff up that is so unbearable to confront in the first place, do we not blow up people's minds further? So that's why I'm still worried, actually. Yeah. Despite the fact that we now have very good data on a decent sized sample, I'm still worried that people will visit very harsh experiences that they're unable to deal with.
I don't want to say I'm unworried, but I think what you said about executive function and other ego strengths say a lot about who might do well and who might not. So anyway, I'll stop there. Thank you.
But I think we really should measure all these things, because we may come up with surprising findings. And, and it's, for me, it was really not surprising at the end that almost everybody who came into the study had developmental trauma, because that's what we see. And we have this notion, they were perfectly normal until the war came by, they saw something horrible, and then that's not how it goes.
Right. Yeah. Thank you.
Thank you.
Great. Yeah, I think, perfect. Yes, Carly's up next.
Hi, thank you so much for this wonderful talk. I really enjoyed it. My question is there any evidence that psychedelic assisted therapy could be preventative against the development of traumatic disorders?
It's an interesting question. Wendy Dandria just did a survey that Rachel was not very impressed with, but I thought it was a nice sort of initial invitation to start looking at something. No, it's not definitive science, but you start somewhere. And she found in her internet survey that people who took psychedelics are indeed able to deal with stuff much better on a day-to-day basis, and possibly prevent it. But what does that mean? You put people on MDMA before they go into fight terrorists, that was done. We know that heroin is a very good preventative thing for PTSD. Doug Bremner wrote about it. I think it didn't get much press. But once your autonomic nervous system is calm, you don't get PTSD. But I wouldn't go for that particularly. I'm curious what Rachel has to say about it. Yeah.
Well, there's a lot of research. The research that our colleague Glenn Sachs did early in his career showed that burn victims who were on high doses of opiates didn't get PTSD either. And rape victims who were inebriated were less likely to then later have PTSD symptoms. Doesn't mean that they were fine in either case. Right. It just means that it prevented that particular symptom presentation. When physicians treat acute trauma with benzodiazepines, it prevents the processing. You do have fewer symptoms earlier, but then later there's a lot of confusion and it catches up with you. So this idea of, quote unquote, preventing PTSD, and we're in the business of that. We have a study ongoing using high doses of, single high dose of cortisol in the emergency room to see if we can contain.
I suggested that to you 20 years ago. And you said, Bessel, you don't know what you're talking about.
It took me a little longer to
Glenn found, when you bring up Glenn Sachs's research, he found another very interesting thing. That the burn kids who had close relationships to their mothers had less pain and required less pain medication.
Yeah.
And so the social cohesion is the major protector against traumatic stress. And that's why armies do relatively well, because if you ever want to see intimacy and closeness, join a combat unit. I mean, very doctor people always talk about men being awful, etc. If you want to learn about love, hang out with a combat unit. These people take care of each other. It's a very important thing. And it allows, as long as your unit is intact, you are less likely to get PTSD.
Yes, unit cohesion. And if somebody from your unit gets killed or injured, you just never get over it either. Yep. So that's is also a very true.
Yeah, we've got to get into the attachment piece because it's so systematically left out. We're monkeys. We completely are attached individuals. I almost start crying when Rachel reminds me about the fact that we have spent 30 years off and on together. We are monkeys who get very affiliated with each other. That's who we are. You know?
Yeah, I think that's because of your MDMA experience, Bessel.
No, I don't think so.
Yeah, no, I agree. That was a really interesting question.
Yeah, it's great. Yeah.
Thank you, Carly.
Thank you.
Thank you. Next up, we have David Jiang.
Hi, David.
Patient psychiatrist at Mount Sinai. I'm also very interested in trauma and the neurobiology of trauma. Thank you very much for the great talk, Rachel and Bessel. I wanted to ask if you see any potential for the treatment of personality disorders like BPD or narcissistic personality disorder with psychedelic therapies, because I hear you talking a lot about issues of self, identity, attachment, relational disturbance, and of course that's massive in that category of illness. Is that a next step in the research or future directions?
That's the big question, of course. Huh? And I'm not going to make this joke in public, but borderline personality disorder is obviously the next avenue. Huh? Like, you know, Judy Herman and I did the first study to show a huge amount of trauma, borderline personality disorder. The study has been replicated at least 25 times by other people. We still don't define borderline personality disorder in terms of childhood terror and attachment problems. The research is overwhelming in that regard. And so you cannot make a connection with yourself because you have not been able to make a connection with other people. MDMA would be absolutely the first order of possibility that you might change that. I mean, Marshall Linehan's intervention isn't bad, but it's not particularly helpful either. You know, it moves people a little bit, but if people can really visit that abandonment as children, what we saw in our research, that abandonment concerns were very sharply attenuated. Self-regulatory systems were sharply attenuated. Our data just points straight in the direction of borderline personality disorder. Good luck, because they're also the high-risk people who may actually have very nasty side effects, but it's got to be done, got to be studied.
Yes, and we are planning that kind of study. We're going to be collaborating with NYU on a study of personality disorder with psychedelics. And if you're interested, if anyone's interested in joining any of the work we do, they should contact Lauren, and we can definitely use interested parties. But that should be a very interesting study.
What's interesting in our research a long time ago, and people do it differently today, was that borderline personality disorder specifically was related to childhood trauma. Narcissistic personality disorder wasn't so much. So I think you need to be very careful what subpopulation of personality disorders you take. Here's my joke. I was in the White House a few years ago, and I beat myself up for not having put LSD in the drinking water, which I could have done possibly. And it might have changed the fate of the world. Like, how do you treat what we see in politics? The only thing I can think of is psychedelics. Just open up the world, and when you take psychedelics, you go like, I'm just a little speck in the universe. The universe is so much larger than I am, but I'm a precious little speck. You know, that is the essence of the psychedelic experience, and that's what we all need. Yeah.
So I'm seeing in the chat that we're getting a lot of anonymous questions about your perspective on using other psychedelics to treat PTSD. What do you feel might be a good idea, might be dangerous? Do you have any other thoughts or opinions about that?
I think it's way premature to call out anything. You know, MAPS, Rick Doblin fantastically has been able to get the money together to do these gigantic studies in MDMA. The Hopkins group has done great studying psilocybin for particular conditions. We don't know if they overlap from one condition to the other. These are all empirical questions. Way premature to predict anything.
Thank you. I'm also seeing some questions of if you think that there really are any contraindications to, and specifically MDMA-assisted psychotherapy, or if there are things that you really think we should not try that you would be concerned about to the point that like it's not an empirical question, that it really should be as a dangerous thing.
Yeah, I would not mess around with people who are psychotic, although that's just because I'm scared. And worried about potential negative side effects. It may actually be helpful. God knows, but I wouldn't have the guts to do it, and my IRB probably wouldn't allow it either. And so there's certain populations of people who are really who have a thought disorder, who have word salad, who have really problems putting things together. I wouldn't try it on. The question: can you try it on people who have no observing ego? Or whatever your term is for that, is a very big question. I do ketamine-assisted therapy also, and I practice it. And I've seen people in our trainings who absolutely have no effect on very, very high doses of medications. We did not see that in our MDMA study. And so I wonder if some people are so rigid that even a powerful psychedelic will not break through their usual defensive systems. But, what I'd like to say about PTSD, this field is basically 30 years old. And it's way premature to make definitive statements about anything. It's way premature to say anything that something is a treatment of choice. We've studied a few little treatments. It's way premature to call things out. That's one of the things I like about Robin Carhart Harris also, is that he's really exploring. And this is about exploring, being very open-minded.
Well, great. I think that's a wonderful note to end our chat. I think we have to keep an open mind and keep exploring. And I think if anything, if our trauma field has taught us anything, it's to not make premature conclusions, and a lot of things will surprise us if we let them. So again, to everyone listening, Dr. van der Kolk is the author of a #1 best-selling book for several years, The Body Keeps the Score, that I really recommend.
Thank you for your blurb. I think your blurb had a lot to do with it becoming such a success.
Yes, I'm sure it enhanced my career. Thank you for that. And so this is the great opening for the second season of the Mindset Lecture Series. And we'll see you all next time. And thank you so much, Dr. Bessel van der Kolk.
Thank you, Rachel. Thank you.